today's topic, I'm honored to have this chance to share and learn with all of you about a simulation and motion management organized by the RCC. So the outline, we will discuss a full topic. One is the setup of devices, and one is about the image registration for the multi-modalities, CT, MRI, and the image registration checking at the treatment machine, and the weekly chart check and imaging what we are looking for. So first, we talk about a setup of devices and patient setup. I will give you more examples. The first one we talk about is brain simulation. The goal of this is to prevent head. How to move this way? Yeah, never mind. To prevent the head motion. So there are many manufacturers. Here, I give you an example, mask without the face. The reason using this one is because some center we will use the surface imaging guidance called VMAT or CRAD or identify so that the camera can see the patient face movement. If all covered by the small plastic mask, then you cannot tell the patient move or not move. But that doesn't mean that's the only choice. Definitely you can have this type of mask if you don't use T type of monitoring. And the point is reduced chance of motion rotation, but the cons could be less comfortable and the patient could be claustrophobic for certain patients. Here, when you do the simulation and you want to check it's a good one or a bad one. And the first you want to check is the patient should be in a neutral position, like a straight line here. This patient a little bit tilt actually, but probably the patient doesn't feel comfortable in the neutral position. We do have certain patients like that. Another one is you try to avoid the patient brain tilted like this way or that way. That really bring problem for the patient setup during treatment. And the mouth pitch and nose very important also. The patient may be afraid to say so, but because the thermoplastic has a piece may press the teeth and mouth, and they tend to change their positions during treatment. Also, the ear comfortable and eye comfortable, and mask may be tied during treatment because it will shrink. So those are very important. You check the physical position and do check with the patient, do you feel comfortable? And make sure the patient feel comfortable and they will not move during treatment. And also certain patients may feel where should I put my hands and where should I put my arms? So give them something to grab. Maybe you don't have that ring, but maybe cloth is okay also. And we have the knee band for comfortable. If you don't have it, maybe you have a roll. That's okay.
Here's a quick question before we move. Sorry, I'm going to go ahead and interrupt you for a second if you don't mind. Do you mind, you mentioned surface-guided radiotherapy. I'm wondering if you could name some advantages of it. They're asking in the chat if you could name some advantages of SGRT.
VMAT, you mean?
SGRT, surface guided. You mentioned
surface guided, yeah. VMAT or CRAD, I'll identify those three. Actually identified before they called the Humanity IQ and purchased by Varian and converted to a so-called VMAT. The surface guidance has true fraction monitoring ability. And when I was at the Memorial Sloan Kettering Cancer Center, for any SRS treatment, we use TrueBeam and we do use VMAT to monitor the patient will move during the culture rotation or during the treatment. And if the move more than 2 millimeters, we'll definitely re-image the patient and double check the location is still okay. For fractionated treatment, like you say 20 or 30 fractions, probably not that important because the thermal mask do have immobilization ability less than 3 millimeters, which is okay for fractionated treatment.
Great, thank you so much. And Javier from Iraq is asking, what's the approximate dose error for breast motion for 3D CRT, free breathing, and VMAT free breathing? I'm not
For
sure.
breast, right?
Yes.
We will talk about that later.
Okay, awesome. Thank you so much.
Yeah. So for head and neck, the difference is you see there's shoulders coverage by the thermal mask. Again, it's an open mask. You can definitely have a closed mask choices. The choice is reduced chance of head motion and less comfortable. And again, the mask for head and neck, you want to make sure it's a neural position and the neck courage. The neck courage is very difficult to match. If the patient doesn't feel comfortable, they will like to stretch their head, and the courage bring difficulty during treatment. Again, the mouthpiece and the teeth, make sure the patient are comfortable. And one patient complained to me once, they said, I feel bleeding in my teeth because I press too much. And the shoulder position, always the problem. The patient shoulder may block the beam. So if the shoulder is kind of head up like that or down, it will definitely introduce more dose uncertainties. And because the shoulder is at least 5 to 10 centimeter, if it block the beam, it will cause a lot of those differences. So not only make sure seam, you have a comfortable position, but also during treatment, you make sure that the position is still the same. Here is the supine breast simulation and immobilization. This is an example of MRI-CT. So you may not use the same technology or tattooed position, but it's okay. The problem, the pay attention we should do is the medial tattoo and the lateral tattoo, and also we call it a shift tattoo because we will tattoo the patient here and shift to the final actual center, and that's the lateral tattoo. So make it things simple. You just tattoo 3 positions. You know, some patients have concern, they don't want to tattoo too much. And we want to make sure the arm position is important. Most arm, if the patient can raise up, you will be up position. Certain patients cannot because they have shoulder problem. And we still try to use medicine to control the pain, unless the patient really cannot do it. And we try to open as much as we can so that we can open this period. And you consider the table height. If you raise too much, you may collide with the gantry of the neck. And also, we do consider the bridging effect. So most patients, we use DIBH if the patient can do. That means deep inhale, breath, hold. And when we set up a patient, we set up with free breathing and ask the patient to hold it, to take the image, to check alignment. And during treatment, you do ask the patient to hold. And typically, we would do this way, say, breathe in, breathing out, breathe in, breathing out, hold, hold, hold. So you give the patient time to respond. And if the patient has a goggle, they can see it. If not, they all listen to you based on the audio. And then you try to calm down patient. Oh, we have 20 seconds. We have 20 seconds. So that patient say, oh, almost there. I can still hold it. Otherwise, the patient may suddenly drop it. And at that time, you have to either your machine has auto enable or you manually pause it. So you have to keep watching the patient during treatment. A larger rotation to one side. For example, if the patient tend to rotate this side or the other side, they may fall during the treatment. So you have to make sure the risk is acceptable. I did see one patient fall during treatment, and that's a really bad experience. And we have to explain to the patient how the whole procedure, why we do this, and that fall is just an accident, not by purpose. So you might need an electron boost in fast treatment. And when you do the simulation, make sure that boost location is also okay. So for example, if we boost this period and that anything blocked this, or you need to reset up the patient later on for the boost. So those are concerns. This image from Linda Hong at MRI-CT. She is the breast lead out there. And
sorry,
yes.
There's a question from Andrea. They're asking how well does surface guided radio SGRT works with the breastboard? Because
sorry, I missed that part. And breast for the typical two-field breast, four-field breast, as surface guidance really good for the initial setup, especially the arm position matching, pretty good. Based on my experience, the boost has challenge because the cone is there, and usually you cannot see very well. Cone will block it. So we have tried, and for certain patients you can still do it, but most time maybe not good for the treatment with boost. And during treatment you can monitor the patient motion, and it's also good enough. So the two sides of popular used for SGRT and then Memorial Sloan Kettering Cancer Center at least is the brain and the breast. We use it a lot.
Gotcha. Thank you so much. And I'm not sure if there's more slides on breast treatment, but for sites that they do not have gating techniques, and they can either do free breathing, VMAT, or 3D plans, they're asking for your opinion in which technique is better and why. And we know that the VMAT plans, the quality of the plan may be better, but if you could share your thoughts on it.
Yeah, it's actually depends on what kind of devices you have at your department. You have to compromise your motion control technology with what you have. It doesn't mean the most advanced one is the best one because you don't have it, So far, the deep inhale, breath hold, if the patient can do, and you have the ability, we prefer that one. At least we kind of freeze the motion, and ideally, but you're not really freeze it because there's still some motion. So if you cannot do it with DIBH, free breathing with ITV planning are still okay, adequate enough. Definitely you irradiate more healthy tissue, but that's all all you can do. And for the planning technology, VMAT and even conformal arcs depends. When I treated the lung SBRT, I prefer conformal arcs because it's so robust. You will not miss it. And with the margin expansion, and it's so reliable. We might, as you know, is intensely modulated, so it's highly required accuracy. And if you miss the one part, you miss the other parts also. So that give you good plant quality doesn't mean you got a good plant treatment, and that's my opinion. So we will continue to discuss this later on, and I have examples, okay? So certain patient, supine definitely is not good because the folding of the breast. For example, this patient, the breast is kind of folded if you use supine. Then prone is definitely a good choice. This is a customized prone board. So we increase the head and give the natural fall of the breast, and we use SSD setup instead of SAD setup to avoid collisions. The key points: the patient rotates towards the lateral side, and the opposite breast shouldn't be irradiated, and because you totally blocked by the board of there, and so that the treatment for the lateral breast and also the heart are pretty good. But doesn't mean that every patient you should do the prone. Certain patient definitely you cannot do so, and the board may also block it, so not ideal candidate. So supine prone, how we choose it still depends. Even though we published a certain paper based on the physical dimension to measure the distance of heart to the chest wall and breast separation, certain things, but still it depends on that patient. And if you can, supine definitely is a popular one. But if you cannot, consider prone also. And next one is long lever SBRT simulation. That's certain cases we asked before about free breathing, DIBH, or even compression. So this is the cervical whole body SBRT board. And the board has a head side and a compression pedal or belt. There's a belt you can pump this belt. And also the knee cushion to freeze the patient lateral shift and the knee roll and the feet, those to help the patient comfortable. And the T cushion is a kind of hard body so that the patient can lay down and without a move. And when we do the simulation, we recorded all the position of these devices. Free breathing, you can use ITV, and definitely it's a larger the PTV size, but it should be okay if you have no other choices. And the compression belt usually is more comfortable, but it is not a hard board like this. And this one, the patient may not tolerate well because you really compress a lot. And some patients complain they don't feel comfortable at all. So that we have to back to the belt to reduce the motion range. If you use this belt, the compression pedal, you may not have to be able to do a full CT because there's almost no motion you can detect by RPM or RGST. The belt, you can still do it a little bit, but definitely free breathing, you can do the motion detection. But certain patients may not have a good breathing pattern. I'll show you next. For example, here is the Holdi CT, and I turn this grid on. This is 1 centimeter grid, so that I can monitor and estimate the patient motion range. For example, for this patient, not only the artifact you can see, but also the range is at least about 2 centimeters based on the grid. Certain patient has a bad, so we call it bad breathing because there's a lot of vibration during this period of time. And the good one is repeatable and smooth. So the typical breathing for a patient is 3 to 12 seconds. Definitely the RPM, they can elongate it to 20 seconds, but usually that means the patient breathes well. For the motion range, if more than 3 centimeters, typically that's not good for free breathing. And you can see the blurring heat effect and larger deformation for the liver and motion for the kidney and the stomach, spleen, and certain organs. And the audio-video coaching, if you have the ability, even through your therapy, are definitely helping. And you can also ask the patient to practice at home, say breathing in, breathing out. It's like a Tai Chi. So that definitely regulate the motion ranges and will help the treatment for sure.
There's a question while we're on kind of motion management topic. If a site does not have gating or any other motion management techniques that are incorporated with their treatment system, what other techniques do you recommend? Maybe voluntarily breath hold. And if that is the case, how do you mark the patient? Do you do it on the inhale and on the exhale? I am gonna go ahead and again mute. If you all could mute yourself, and if not, I have the capability of doing that. But yes, sorry. If you could elaborate a little bit on that. There's a question from Bilal from Jordan.
Yeah. So we used to discuss this. We call it the Perman measurement. You can develop a simple perpendicular ruler.
Sorry, I cannot find who is not muted, but
That's
if you all
okay.
could mute yourself, that would be great. Yeah. All right.
So you can develop by yourself a perpendicular ruler. There's a longer ruler like this, and there's a sliding ruler. You can slide up and down so that you can put on the patient body and ask the patient breathing in and hold to touch the bottom of the ruler so that you can record down how much the ruler height is and still help. I think it still help. I didn't do a good study on it, but it's well interesting to see that one maybe help a lot rather than free. Okay. All right. Okay.
Sorry about that.
No problem. No problem. And here's the spine, either SBRT or regular spine. For the spine patient, they really have pain, a lot of pain. And one thing they tend to do is tend to tilt it to one side. I have some sciatic nerves. So when I stand, I usually stand one side higher than the other side. Same thing for the patient. The patient may tend to slide to one side. And so that you make sure, do the squat, make sure the spine is straight. And if needed, the patient may need a vacuum lock or some knee cushion to make sure they don't move it. And they'll check it during the treatment also. So usually we don't use a small mask unless the patient really cannot hold it. They kind of shaking during the table, that's not good. And again, spine straightness and white lock, and consider where the spine disease is. Maybe the C-spine, T-spine, our spine. The C-spine, you may pay attention again to the curvature of the head and the neck. And T-spine, the L-spine, the straightness are also important. And also patient may be in pain. So like I said, the curve of the spine in AP and PA, anterior posterior directions. And next is the stomach is a very difficult one because it depends on the MD. Some MD may prefer the stomach empty. Some may have a contrast so that they can control the stomach well after treatment. But the stomach is so difficult to make sure the shape is the same size and the size is the same. But we usually typical as the arm up, if the patient can, to expand the stomach. If the patient has a pacemaker or chemo port, make sure they are outside of the field. Here, there's a good topic, pacemaker, ICD, immobilization. I just did a APM session about it. If you have the chance to view it, Dr. Maria Chang published a paper and also gave the presentation very well. So the key here is make sure the electronic devices are outside of field and less than 5 gray. That's the take-home message.
Great. Before we get too far from it, do you mind explaining the ruler technique that you were mentioning earlier?
Yeah, so make a vertical ruler and fix on the table. Make a sliding ruler, maybe a little bit, screw, and so that you can slide and immobilize it. So that's a very simple design. I think most of the country should have this kind of ruler.
Yeah, actually, a great point. Thank you so much for sharing that. And another quick question: how do you take into account any devices that you use for immobilization and positionings in your treatment planning system? Do you contour them?
Very good topic. The vacuum for photon, you don't need to consider it. For proton, actually, we try not to put any immobilization device in the treatment field. So the photon, like a spine, you have vacuum. For proton, you don't have it. The patient will lay on the table. And the couch, you model it in the treatment planning system. And if you don't model, may up to 3 to 7% differences. For other carbon devices, it's still okay. The treatment planning, most of the treatment planning system have the ability to calculate accurately. If you have metal, like a titanium, steel, aluminum, or copper, those you give them a correct Hans unit. Or your Hans unit to density table robust and expanded to high density. Yeah.
Great point. Thank you so much. And what about the chemo port and the pacemaker in breast?
That doesn't matter. Chemo port doesn't matter. It's just some part. So you can tolerate the radiation. Pacemaker electronic devices, again, 5 gray is the take-home message. Try to make sure it's 2 gray. Depends on the brand, actually.
Thank you so much.
The cervical simulation, if the patient can do a prone, that will be great. It's good for the beam setup. But supine is also okay. and maybe comfortable a little bit. Certain patient may have skin folding about this area. If you have the ability, make a cloth or wax, so to separate them a little bit, and that will definitely help for the later skin toxicity. Make sure you immobilize the upper and the lower. Most patients are still in pain also, so that they don't move during treatment. And prostate usually, relatively simple. You can immobilize the upper and the lower body and make sure check the straightness of the body. Bladder is the key. Bladder is difficult to make sure it's the same size and full. We guided the patient to empty bladder first and drink about 30 ounces of water 30 minutes prior to your CT simulation and treatment. So if you have the device, you can check the bladder volume. It's called a bladder scanner, and very convenient. Or use the ultrasound to check it. But if you don't, and then you check with your KV or CBCT are also okay. Make sure the patient, if too much or too less, and you can ask the patient to take off the table and adjust a little bit. Empty rectum, if you have the ability, use the device called a spatial OAR, definitely help. A patient have something hold in hand. For prostate SBRT, spatial OAR almost must. Definitely reduce the rectum toxicity. And do check the bladder contents. Otherwise, the bladder will push the prostate away and so does the rectum. So if you don't have those devices, I don't recommend you do a prostate SBRT. Yeah. The arms, extremity, leg, arm, anything, you can immobilize it and mark a certain key points and make sure the patient do not move. That's all. But if you have the safety couch, I mean, the couch can rotate, the pitch roll, pay attention to it. You may use it too much and divert the beam into this part of the body. And it happened to once, the patient got a skin toxicity. And we wonder how come. You are treating arm, how come the body has a problem? And then we found out either the arm, you adjust too much in and out, or the beam may divert into the skin area. So don't use too much. And you do use your common sense to check the patient setup. Again, the femur simulation, the patient in pain, you make sure you mobilize the legs and the upper body. Same thing, patient comfortable is first. Axilla, we give an example, axilla simulation with bolus. And that definitely help for planning and make sure the bolus are in the same location and the same size. But if you forgot it or you don't want to, that's okay. The eclipse treatment planning, you can put a uniform bolus, maybe bigger, like that, and you can do it later on. Shouldn't affect too much. So for the summary of setup patient devices, balance the comfortable and the immobilization, consider treatment planning beam setup against collision, consider reproducibility, use necessary immobilization device according to your department, what you have. Organ full or empty, consider it like stomach, bladder, rectum. For the CT motion management, free breathing, gating, or compression, as low as reasonable achievable. So do what you can. Do not do what you cannot. That sounds like complicated with each other, but that's the best that you can do for the patient. If you can schedule the CT with MRI or PET immediately or sequence, that would be great, especially for brain SIRS, so that the patient will in the same location. While the actual implanted devices, such as ICD, pacemaker, something like that, and follow scan protocol according to the vendor. So that's simulation. Any further questions?
No, I think we have addressed all of them. And okay, I am chatting with individuals, but this is going great. Thank you so much.
Okay, let's continue. So next is image registration for treatment planning, involves CT, 40CT, MRI, and PET. So registration, here is the 40CT area was, here we do not do the deep inhale, we do the deep exhale, that like a kind of compression belt. And the difference is ask the patient to actively to do it. So you see that here's the grade, and you can see the differences, right? You can see the differences. This one I did register it, but it didn't show the same location of chrono at least. But you can see they are deformed and there are differences. And the registration depends. It regists to the bone or regists to the organs. Here is the fusion of average and so-called EEBH. So if the patient can hold it, now let us the patient hold it. If you cannot, you can use the 40CT to do the average. You see the difference? And compression belt might help. And the gating windows choice depends on your department guideline. Typical is 30% to 70% enough. Checking and prediction are so advanced technology. You may not need it and you may not have it. That's okay. The other choices are still available. So if you don't register well, those are the subsequence. Improper target contouring or AOR contouring, improper treatment planning, development, improper dose accumulation for sure, improper image guidance for later on, and improper understanding of the clinical outcome. You say, I did everything I can and everything looks reasonable. How come the patient got a different response, right? So here's the APM task group 132 guideline, and it shows the MRI-CT registration. For such kind of, for example, the brain SRS, when I check the patient, I check not only one plane, you check multi-planes, you check multi-feature points. For example, you see here, right? The alignment, the MRI and the CT. And also, this is good features, right? This is a good feature, and the make sure the line are straight and also in millimeter tolerances. And certain eyes or certain bone here and nerves, optical nerves, those are good features. And if you can see the differences of the images, also help you say, oh, wow, it's good. And depends on what kind of treatment. As you try to make sure it's 1 millimeter, and other side, maybe 2 or 3 millimeter are still okay, but you do your best, you can do.
And sorry, before we get too far from breast, there's a question about bilateral breast or chest wall treatments, and if there is a collision issues, do you have any insights or tricks that can be useful?
Yeah, we measured the bottom of the couch to the cone or collimator length. I remember it's about 32 centimeters for conservation. And also you can roughly draw on the treatment planning and expand about 50. I think it's about 50 centimeter for the collimator. And this is about 35 or 32 centimeter to during the planning. And then make sure it's within that tolerance to avoid setup issues. And you can dry run it if you ask a therapy to check it for you. Or move the actual center. The actual center doesn't need to be exactly the same as the market actual at treatment. You can move it later on, right? You can move during treatment planning to avoid the setup collision. If unfortunately you still have collision because the patient maybe arm position different, and well, unfortunately you have to replan it, and there's no other choices. So again, when I check the brain SRS and MRI, I check multi-sites, check the tumor for sure. You check those feature points, feature lines, feature critical organs, and not only one plane, check multi-plane, check multi-location. Even though it mathematically assume the brain is a rigid object, you just need a full non-coplanar points. But you never check full. You check multi planes and multi locations, and give you comfortable.
Yeah. Mohammed from Sudan is asking, what if I can't use my fixation in the MRI? Should we image without them, keeping the position as close as possible? Or what do you suggest?
So they don't have MRI.
Mohammed, do you mind maybe elaborating? I'm not sure if I also understand it, using my fixation in the MRI. And also there is another question for registration of CT to CT.
Fixation in the MRI. Okay. So that means that they have MRI, but they cannot fix it, right? My understanding is.
Yes. What I mean is that my fixation doesn't.
Yeah. Okay. So that one, during the registration, you will involve the rotation. A certain patient may rotate a lot. And in your brain, you have to have 3D visualization of the brain. And it is difficult, I know. When I use the I-plan treatment planning, it's so difficult to adjust the rotation and make sure that align with CT not only in one plane, but also in 3 planes. And you have to try your best, the multi-size checking again. And a certain MRI may have deformation, the artifacts. So you understand the risk. At least you align the tumor location first, and then fine-tuning the nearby critical organs, and then further organs as well. So if we can continue. Yeah.
So what you suggest is I do a local setup, then go further ahead.
My suggestion is use the treatment planning rotation, pitch, roll, and pitch, roll, and the rotation to 6D readjust the MRI with CT. And in human, you have the visualization of what a CT is, what a MRI is, and this MRI is roll, or is pitch, or is raw rotation first, mainly, and then adjust it to match the tumor nearby organ and further organs. Otherwise, you may come out a solution nearby tumor match it, but the further organ mismatch it. And then you have difficulty later on. Either the OAR match or you cannot match well at the treatment.
Thank you.
Thank you so much.
Yeah, here's the multi-modality MRI. You can see MRI-CT, CBCT registration. And again, check the feature points you can grab. It's not only one feature point, depending on site. Here is the curvature of the bone, like this bone. And here is a feature point, even though it's further from the treatment area. And also, I like these lines. These lines are pretty good on both MRI and the CT. And if you can, also check those curvatures. You see the darkness, and those are highly variable on MRI and both CTs. So make sure you check those things also for the accuracy. Another is like, for example, the patient has surgery, and they have, see, here the skull gap. Those are good features. I just give you an example where the good feature to check. It's not one, it's multi, and also depends on where it is, right? So those features, the courage and this courage, those are good features. And you definitely screen and out to check multi-planes and multi-chronal, sagittal, and also the axial. And here you see this is MRI is rotated. This MRI definitely rotated. And then when you do the registration, I think you can drag this direction and that direction to rotate it. And it's very easy you mismatch it because the score is about like a ball, for a ball, how you match a ball, point by point. It's usually it slide around that direction. So that's why you make sure that you check those feature points are good to match each other. You know you are not rotated too much. And definitely PET becoming more common in clinic. For example, there's a modality called reflection. It's PET-LINAC. It integrate PET's ability with LINAC. It's similar to MR-LINAC. You heard about that, right? MR modality with LINAC. Here, the PET, we lost is function image. You lost the anatomy. Some certain anatomy is still there, like the spine, right? And you can use that to match your CT if you don't have PET-CT. But if you have the PET-CT, use the CT to CT registration more accurate than the PET-CT, because PET, the resolution is how much? 5 millimeter, 7 millimeter. CT, you can have resolution 1 millimeter, 2 millimeter, 3 millimeter. It's higher than the PET, right? So CT to CT are more accurate than the PET to CT. Unless you have no choice, you only have PET, right? So you use the feature, anatomy feature like the liver, like the spine, and match it, and then match it with the CT, and especially pay attention to the tumor location. So again, check multi-planes. Here's the PET registration to PET, has a low resolutions. You see how difficult it is. Do ask the radiology if you have the connection and IMRT to double check it for you, and so that you are more comfortable. CT has no function information, but CT has a high density information well, the bone, and also certain patient may have the calcium of the blood vessels. Those are good features to check also. So if the patient has markers, like a surgery marker, or the marker you implanted into the liver or lung even, that's good features. And certain anatomy, like the liquid in the lung, may not good to use as a feature, because the patient may have liquid in one scan, another liquid, no liquid in another scan. So you mostly use the Bony, and if you cannot see it, you can contour the common organ out. In one side, you contour spinal cord. In another side, you contour spinal cord, and use the contour for registration to help you regist it well, right? It's an extra first, but you improve the accuracy. Again, the bone are good, and you see that the patient has, especially elder patient, they have the calcium of the blood vessels, and you can use that features to make sure the great blood vessel to align it. And the spine, for sure, you can use the mouse or keyboard to fine tune it. And the heart, and this one we control out, and we use heart for registration, very helpful. And PET-CT, the CT has the CT with the PET has the same coordinate as PET. So they have the same coordinate, and your planning CT may have another coordinate, but the CT to CT registration first, and then the PET will auto align it. So again, that if you can, try to use that. Any question from the chat?
I think we are good. Thank you so much for checking in.
Okay. And next, PET-CT registration function organs can help you check it. Like the tumor, both tumor may respond, and the brain definitely responds, and then you can use that to double check it. You courage instead of anatomy information, or heart may have certain response for the contrast injection, so that you can check the head neck and check that location well. And for the brain, if you can align the skull well, that's good. You see, the tumor is here and there. We can check those skull alignment and those skull alignment so that you feel comfortable. And the base of the skull, those are good features to check. So again, for summary, you check the CT contrast. If it's rigid, you have the bone. That'll help you a lot and easy to check it. If you cannot see clearly, contour them out. Use the contour to help you. And function MRI or function PET, you can use the organ to check it. And one more time, check multi-location, check multi-plane. Here's another example, PET to MRI registration. So the main organ contours and the structures and the nerves, those are good features, especially this line. That's a good feature to check it for sure.
Shirin,
Sure.
sorry, before we get too far from registrations, Shirin is asking about your opinion about deformable registration and how reliable do you think it is?
That's the next slide. Good timing. So what we discussed are rigid. Rigid means only involve shifts, X, Y, J, rotation, pitch, roll, roll. However, we know we are all organs are not rigid. There's a lot of deformations. And you can see the lung motion, liver motion, those definitely deformed. And unfortunately, so far, we don't have one algorithm, like demons, like a multi-mutual information, any information registration algorithm cannot do rigid registration, non-rigid registration so well. You can believe it, but you are trying to blind your eye to shoot a bird. So that means if you want to double check your treatment planning non-rigid registration algorithm, use the task group 132 Phantom to do it first and give you comfortable. But I don't believe it. I don't believe it for sure. For research is okay. For the real treatment, I have a big question mark there. I'll put a more uncertainty there. But you can still do something. So you match the OAR for RI first and sacrifice the others. Because non-rigid, they usually cut the body into pixels and they use each pixel, they still assume a rigid and do the rotation and shift to deform it. So that your organs, what you are interested and focus on that. The rest, maybe, well, you have to forgive those rest. And I do not suggest for pelvis, there's a lot of organs there and there are a lot of deformations. For example, intensity, larger intensity, small intensity, they are not the same. No one can register it well. Even radiologists, expert radiologists cannot do it. So that's a good research topic, but I don't recommend it you use too much in your clinic. Again, the summary for checking is check at least 3 locations for 2D and 4 points for 3D for non-coplanar points. Check 3 planes and different slices. Use the blue amber for rotation. You can slide it. You can slide this way, that way, and your eye will have movie effect, and you can see the rotation. Use the split screen to double check both modalities, and adjust the window level for better vision. Like lung, pelvic, and liver, brain are different, right? Check differences of the image. So that means one image minus another, and see where there are differences. And check the region of your interest. And if you're not comfortable, ask MD, radiology, your coworker to double check for you, especially SRS, SBRT. Fractionated treatment, they may forgive you a little bit uncertainty, but SRS, SBRT, you wrong, you lost a lot, 20%, 30%, maybe the whole 100%. And summary, rigid is used widely. Most of the people use rigid. And non-rigid, good for research, but you have to double check it and have concerns. So use the different images, the pros as much as you can, and you know the limitations. Check multi-plane, multi-location, and use Contra to help you do the registration and checking. More and more conventional treatment can benefit it, especially with good treatment. The patient may come back. Brain surgery, multi-mass brain radiation, spine radiation, those modalities will help. Any questions? I see some.
No, we have, I believe, Ben, who's also elaborating on some.
Okay, let's continue. Yes. So registration at the image. I'll give you some samples. Okay, for example, brain. Yeah, the brain, the skull is good. Anatomy check it. I don't think the patient brain will shrink or enlarge or certain things happen during treatment. Just in short period of time. Rotation is also happens. So you can use the blue amber to check the rotation, either CBCT or QV pairs. So bony anatomy definitely for sure. Head and neck depends where it is. If it's a nasal head and neck, for proton, we pay a lot of attention to the nasal feeling actually. The patient may have feeling liquid during one treatment, but may disappear another day. So proton, maybe you have to reimplant. But for photon, even though there are differences, it's okay. Fractionated is definitely okay. Continue treatment and do something after treatment. Don't be panic, okay? It's okay. And definitely the dose anatomy is a good anatomy to check it. There's a high contrast anatomy. It's easy to check it. And spine. The spine cord definitely is the major concern. So you have to make sure the spine cord area, land well. In certain cases, the patient may lose weight, or maybe they have skin folding or something. If you can reset the patient, make sure the patient can adjust it, that would be great. If the patient does lose a lot of weight, make sure the matching part are not in the beam part. And if you use the whole body, actually the good news is the photon planning will forgive those differences. And you may replan after that, but that fraction is okay. So just do another scan and replan it, okay? And the stomach, again, stomach is really, really challenging. So that's why we fractionated and give a larger uncertainty for planning. And we don't even use CBCT, for checkup. You just use the Contra to check it. And it will not be the same every day. It will be either empty or full for certain days. But you give the patient protocol and say, don't eat or don't drink some water or something like that. Eat a little bit, just keep it consistent. Here's the pump brass two-field setup. Remember, we do the free bridging setup and shape the patient, and then do the DIBH for treatment. So when you do the imaging, so you check the DIBH alignment for the chest wall and for the body contours. And then you guide the patient for treatment. Again, check the tabletop, the collision, something like that. So the DIBH to alert the position of heart versus chest wall, and the tangent will less hard, about reduce the percentage of the heart irradiation and the lung irradiation, cause the Linda Hung of MSK. So this is DIBH. If you don't do DIBH, you do free bridging, you don't have the ability. I think it's fine. It just give a larger uncertainty for planning. And this is a prone treatment. Again, is SSD setup. Why? Because of the clearance and the gantry may collide with the spot. And for patient clearance and Gaussian movement. And the SSD also help the therapy can check using the light field, check the number. Certain time, they may not be able to see it, but we can still check it on another side. And at MSK, they also readjust the laser. So the laser can tilt it and irradiate the laser from the bottom of the flower and can see it. But you don't need to do that. Most of the time, the light field can still see it. Cervical checking, for example, this patient not only have this major tumor, but also we call the butterfly lymph nodes. It's so difficult to check. I will use bony anatomy for matching first and pay attention to the soft tissue misalignment or weight lost. And the prostate, same thing. Prostate, not only the primary tumor, but also lymph node nearby. And again, bony anatomy, check first and pay attention to the bladder fullness and rectum shape. Bony anatomy, like a femur height, femur, or attention to the bone checking and the kiwi, MOA, you can see it. But like I said in the beginning, pay attention to the safety culture usage. Don't use too much and then may have some effect. Here's the axillary setup. You use kiwi to check the bone. You can see clearly. Okay. And the spine pelvic setup, bony anatomy. pay attention to the spinal cord or cauda, because that's the major organ at risk. Here's one topic is corresponding the previous question. The patient may have the spine screws, the titanium screws. And if you know the materials, assign corresponding Hans unit. For photon VMAT, actually, it's not that bad. The dosimetric accuracy is okay, especially when you have the calculation ability. If you use static beam IMRT, try not to shoot directly. Exiting dose is okay, all right? Summary of image registration in the machine. You know you're a therapist. They want you to do it quickly. So you have to be very efficient. You know the software, you know what you want to check ahead of time. The location, what I supposed to check, where I check it, and then you're right there. But do not hesitate to ask them to readjust the patient if you really need it, okay? Know your patient before you check it, and bony, soft tissue, or Contra help checking. Image technology, KV, or MV, or CBCT. Reset up the patient if you really feel necessary, okay? Fiducial markers might migrate, okay? You check it, it's good, but you may migrate it, make sure you double check it. Check multi-plane, multi-size. Pay attention both PTV and OARs, okay?
Great,
Any
thank
questions?
you so much. Yeah, Nicholas is asking if you could kindly explain the difference between image registration and image fusion.
Okay, image registration is computer algorithm to readjust the one image site to another. For example, CT to MRI, PET to MRI, PET to CT, or even CT to another CT. Because you scan these two images in 2 days or 2 modalities, their coordinates are differences. That's why you need a registration. But they have one common thing. The coordinate is the same, that's the patient. So that's why you still can. So the registration are based on the patient physical coordinates, not the image coordinates. So the patient coordinates will not change. Image coordinate will definitely change. Fusion is after you image registration, you merge these two modalities together, give you the vision view of both, like the PET function size on the CT and the MRI function flow on the CT, or another CT ability, diagnostic CT contrast on your planning CT. So that give you mutual information to help you control or make a decision. Does it make sense?
You said it beautifully. Thank you so much.
Let's do the last part. Thank you for staying with us. And the weekly chart check and the imaging. What are we looking for? So here's the TG APM 275 guideline. So we check a lot of things. Sometimes we couldn't even remember what are we supposed to check it. So you check the imaging fusion again, according to the MD directive, or even more, okay? You check the machine matching structures, reference CT, or 2D or 3D, DRR, image quality, image technique, an image, like a weekly or daily, or pacemaker, or the other modality like exact track, winner RT, RPM. Are they still the same? And the ISO center is the same. The reason is at a machine you are kind of a time limited. You may have 3 to 5 minutes for the checking, and now you have more times. You can look in more details and double check your co-workers' work. And the general scenarios wait last. If you cannot correct at a machine, for example, the patient did lose a lot of weight, and you say, oh, today fractionated because it's 30 fraction, today is okay. But doesn't mean it's okay for you. You go back and simulate the scenario at your treatment planning to check what's the dose differences. Maybe that day you have 10% or 20% for that day, but for whole treatment is still okay. So you can make a decision, should we replan this patient or should we just continue? Because the replan may costly for the patient also. So again, nasal filling, like I said, proton are important, photon may not be that important. Implant device, pacemaker, ICD, what's the dose? And the shoulder, what's the effect actually? If the shoulder blocked the beam, what's the effect? And shifts are not applied. Oh, yeah, it happens. It saw the rejection pretty well. I say, let's treat it. And the therapy forgot to shift it. Row systematic across the fractions, that's something. That means something, That means either the patient anatomy change or the therapist really just depends on auto registration and give you a systematic idea. And most important, what's the dosimetry effect? And do communicate with the MD and see we need a replan or not. Put the alert for the patient future action, like pay attention to the shoulder alignment, or pay attention to the nasal feeling, pay attention to the weight loss. If it still continue, let's replan the patient so that you are on the same page, okay? And you may email the whole group to alert that, that patient need further alert. Any questions? Okay.
We're all good, thank you.
Pop-up quiz. What I should do? You have the control?
Yep, I do.
Okay.
We can read the question and I'm going to go ahead and launch the poll.
Okay.
Yeah.
Would any of the following scenarios be okay to continue without replanning? Prostate patient treated with VMAT, the patient has lost 1 centimeter, and let me disable mine. Tissues all the way around the body at the level of prostate. B, head neck patient has lost some weight. The mask still fits well on the face, but the shoulder has dropping inferior from the mask by 1.5 centimeter daily for a week. Lung patient, you notice the blurring of the tumor on the CBCT appears to just touch the edge of the PT weight. Wawa patients, you notice the patient has some swelling and now the PT weight on the CBCT appears to extend about 1 centimeter past the initial planning CT. The original plan was not planned with flash. You notice a Bauer loop is in the same place, air fraction, touching the SIB, simultaneously integrate both paraorbitic node boost. All of the following scenarios should consider replanning.
Awesome. I have already launched the poll. Yeah. I've already launched the poll and I see the participants are putting in their answers. This is great. Gonna maybe give it a couple. Oh, okay. Did you already do that? That's okay.
Yeah.
No worries. That's great.
Yeah,
I'm gonna go ahead and end the poll. Yeah, we are a little over time. So thank you for keeping us on track.
Yeah, so the prostate, usually the VMAT has a forgiveness for differences. And I did publish a tomotherapy plan comparison, and later on people publish VMAT, so they're okay. But others may not. You know the tricky, usually all of them or something, that means it's not good. Only all or something like a keyword like that, that's not a good answer. So when we give the ABR exam, I'm an ABR exam, a general exam writer, we will never use that word. So the others, there's definitely those differences. So from conclusion, simulation immobilization is essential, garbage in, garbage out. You simulate it well, you treat them very well. Image rejection error will cause those dosimetry effect for sure. Any small one, it will have difference. It just depends on to what kind of degree. Setup alignment is complex and needs dosimetry physicists to have sometimes, especially SBRT and SRS. Weekly chart check review of setup image may help prevent further damage to the patient. And thank you for listening. That's some reference for motion TG 76 for the chart check, 275 for image registration, 132. Thank you.